دوستان خیلی خوشحالیم که آقای دکتر مظلوم طالبی رو داریم، متخصص داخلی، متخصص قلب، فوق تخصص الکتروفیزیولوژی، دانشگاه ملی ایران پزشکی خوندن و بعد در USC تخصص دیدن، در UCLA فوق تخصص و کلیولند کلینیک دور دیدن و خیلی خوشحالیم که در خدمت شما هستیم. در داونی کالیفرنیا پرکتیس میکنند و کنفرانس های متأثر بودند، مقالات نوشتند، کارگاه رو انداختند، ترین میکنند دانشجوی پزشکی رو، رزیدنت ها، فلوها و غیره. واقعا متشکرم که برای ما راجع به کاردیاک اریثمیا میگین دکتر.
خیلی متشکرم. ممنون از دعوتتون. دکتر نواف وقتی دستور میدن از تو یک اشاره از من به سر در بیاد. My task today is that من بیشتر صحبتی که میکنم به انگلیسی خواهد بود. اگر دوستان یه وقت لازم شد بفرمایید فارسی هم میتونم بگم. و اگر اسلایدهای من یک مقداری کامپلکس هست میبخشید، چون اصولا این کاردیاک اریتمیا و الکتروفیزیولوژی یه مقداری فاندامنتالی کامپلکس هست. من سعی میکنم این رو به زبان ساده تر بگم. اسلایدهای من زیاده. در واقع این اریتمیا 2 سال ایژوکیشن من هست. I have a lot of slides here که over years من اینو درست کردم. اگر دکتر نواب صلاح دونستان من میتونم این رو در یک part 1 and part 2 براتون پرزنت بکنم.
خیلی ممنون.
بله بفرمایید. خب شروع میکنیم. وقتی شما به you look at electrocardiogram, the fundamental part of electrocardiogram, you see a hump, we call it P wave, which is atrial depolarization, upper chamber of the heart activation. Then there is an interval here. Then there is a complex is called QRS, which is activation of the lower chamber of the heart electrically. We call ventricular depolarization. And then after an interval or a segment, there is another hump or a heel-like structure. We call it T wave, which is ventricular repolarization. So I said depolarization and repolarization. Depolarization means activation, electric activation or excitement. When a cell comes out of the resting potential, the resting state, to excited or arousal state. And repolarization is when the cell goes back from the polarized or activated state to resting state. In electric conduction of the heart, there are different components: SA node, interatrial fiber or Bachmann bundle, atrioventricular node, common bundle of His, right and left bundle branch, and Purkinje fiber. So this is the picture of the heart: right atrium, right ventricle, left ventricle. Normal activation starts from a node in the superior aspect of the right atrium that generates impulse. That would travel through the Bachmann bundle to the left atrium and goes all the way in both atria and comes down here at the lower septum of interatrial septum in a structure called atrioventricular node. And from here, it penetrates to the membranous septum, to a common bundle of His, then divides into right and left bundle and rapidly goes to the ventricle. Each component have a different action potential shape, which I'm not going to give you headache by going through all of that. And we already talked about different component of the QRS. So in this cartoon, you will see that action potential start from SA node and propagates to the atria, and from AV node, if you pay attention here, right here, it goes to the bundle of His and both ventricles will be activated. Different part of conduction system, if the superior part fails, can be used as escape rhythm. Sinus node, normal rate is between 60 to 100, which is the normal node. If sinus node fails for some reason, there is an AV junction, which is near AV node, that can generate impulse between 40 to 60. And if this one fails, a ventricular junction can generate impulse between 20 and 40. Therefore, if you believe in God, and if not God, if you believe in nature, has put many, many safety gates to not to lose heart rhythm. If you look at the ventricular myocardial cell، سلول قلبی در ventricle or بطن چپ و راست یک همچین پیکچری داره. And my point here is that when the QRS start, the early phase of action potential, that cell becomes activated from resting to fully activated, and we call it depolarization or phase 0, is caused by opening fast sodium channels, and sodium, millions of atoms of sodium or sodium ion go inside the cell and make inside the cell more positive. And then there is a plateau phase, which is responsible by influx or ingoing of calcium, and then repolarization, or going from activated state or excited state to resting potential, is caused by opening a potassium channel, potassium going out through rapid and slow potassium channels, and bring the cell back to the normal state through the repolarization. And you see that is depicted on top of T wave. So depolarization, sodium goes inside the cell, repolarization, potassium comes out of the cell. There are three main mechanisms for abnormal rhythm formation or arrhythmia. One of the less common is abnormal automaticity. Look at here how normally a resting potential should take this much to get to the, to the threshold and cause action potential. But that can become abnormally faster, or it can start in a tissue that is not supposed to have automaticity. This is called abnormal automaticity and is one of the focal arrhythmias. Focal means that it comes from one portion or some part of the heart. The most common cause of arrhythmia is reentry, which I'm going to describe better in the next slide. And another less common is called trigger activity, which is caused by calcium influx at different part of the repolarization. It's called early after depolarization and delayed after depolarization, which I'm not going to go to the detail of this. This is even complex for a general cardiologist. Just know that there are three main mechanisms: reentry, trigger activity, and abnormal automaticity. But what is reentry? Reentry is that when there is a unexcitable tissue and there is Dr. Navo, I think someone has to mute.
Jana.
Man, I can hear some background. I think some of our friends are.
بله. پس من همه رو میوت میکنم، شما دوباره آن میوت کنید. بله.
صدا من میشنوید شما؟
بله بله. مرسی.
Okay. So when propagation of or action potential comes, there is a slow pathway and fast pathway. The fast pathway rapidly goes down here and go to the ventricle, for example. And that's a normal state. But then there is the ectopic beat, premature beat, a premature atrial contraction, or a PVC comes. That, because the fast pathway has a slower refractory period, blocks here. So slow pathway get a chance that slowly go down. And because it goes slow, by the time that comes here, fast pathway comes out of being not activated. So it's ready to be activated because of this slow conduction. This become active, again goes down, come back up, goes down, come back up. And that's how reentry starts. Therefore, for reentry, you need a non-excitable gap and two different fiber or pathway with different refractory period and a premature beat. These are requirements, and this is the most common cause of arrhythmia, including supraventricular arrhythmia or ventricular arrhythmia, which is a fatal rhythm and kill the patient after myocardial infarction or heart attack. So some terminology, tachycardia is when the heart rate is more than 100 beats per minute in adults, and bradycardia is when the heart rate is less than 60, usually in adult while awake, because heart rate of 50 or 40 while we were sleeping, although it's bradycardia, but is normal. Now let's start with sinus rhythm with abnormal rate. When we say sinus rhythm with abnormal rate, meaning sinus tachycardia or bradycardia, these are not real arrhythmia. Why? Because the rhythm is still sinus, is a normal rhythm, but it's faster or slower than expected. So let's start. Sinus bradycardia, rhythm is normal. So I would like to invite your attention to the terminology rate and rhythm. So rate is the heart rate when you take your pulse, and rhythm indicates where your cardiac rhythm starts. Is it from sinus, from atria, from where? The sinus bradycardia heart rate is as low as 60. Conduction is normal, and P and QRS and morphology on the EKG is normal. Like this. That's a P wave, that's a QRS, is normal, but the interval between this and that is prolonged. This heart rate is about 40 beats per minute, which is lower than normal. What are the causes of sinus bradycardia or slow sinus rate? High vagal tone, parasympathetic tone, like we see in athletic hearts, like a marathon runner, or in GI diseases of pancreas, liver, stomach. Sleep apnea, condition that you stop breathing at night while you're sleeping, and that condition might cause you to have a slow heart rate. And medical conditions such as extreme weight loss or anorexia nervosa, that will cause slow heart rate. Coronary artery disease, heart attack, hypothyroidism or low thyroid function, hypothermia, conditions that the body temperature goes below normal, increasing pressure in the skull because of tumor or bleeding, some liver diseases that patients develop jaundice, Yaragon because of obstruction or ensedade مجرای صفراوی. And some infection, usually infections cause increased heart rate, but some listeriosis or typhoid fever, salmonella, actually can cause slower heart rate. And medications such as beta blocker, calcium channel blocker, or cancer medications. So how do we treat slow heart rate with sinus? First, symptoms: decreased cardiac output, chest pain, shortness of breath, low blood pressure, dizziness, lightheadedness, passing out, and exercise intolerance. When patient want to walk a little bit, start to feel weakness and fatigue and cannot walk. How do we treat? If the patient is symptomatic, we treat it. We remove any medication or treat any underlying cause if we can. Like if the patient is hypothyroid, we treat thyroid disease. There are medication can increase the heart rate, such as atropine, which block parasympathetic, or isoproterenol, which increase sympathetic. But basically is a pacemaker implantation. One of the procedures that I do is the pacemaker implantation, and we artificially pace the heart. This is the pacemaker. That's a lead in the atria, and that's a lead in the ventricle. Now, sinus tachycardia, or patient has a normal rhythm, but heart rate is faster than 100. Again, rhythm is normal, but the heart rate is faster than usual. Like this, you see, in this electrocardiogram, the interval with this complexes is very short. The heart rate of this patient is 150. By the way, a formula, so heart rate is faster. Maximum normal sinus rate has a formula 220 minus age. So for someone who is 60 years old, 160 is the maximum sinus rate. If the heart rate is more than 160, if it's 180 in a 60-year-old, cannot be sinus rhythm. It's definitely abnormal rhythm. What are the etiology for sinus tachycardia? Diet, caffeine, smoking, nicotine, cannabis, cocaine. Oh, I forgot to write, I created this slide just an hour ago. Alcohol. Alcohol is one of the #1 causes for all forms of tachycardia, including atrial fibrillation and sinus tachycardia. And then medical conditions such as anemia, when your blood count is low, fever, shock state or bleeding, pain, low blood pressure, heart failure. When your heart pump function is abnormal and cannot pump on each stroke volume, therefore heart has to pump faster. Instead of 80 beats per minute, has to do it 130 per minute in order to create cardiac output. Coronary artery disease, angina, heart attack, and some medications such as blood pressure medications, hydralazine. These are all causes for sinus tachycardia. Treatment of sinus tachycardia is by elimination of etiology. If the patient has infection or fever, treat that. If the patient has anemia, low blood count, either give blood or treat anemia. If a medication caused that, remove it. But if you want to treat symptomatically, medications such as beta blocker, propranolol, metoprolol, and calcium channel blockers such as verapamil, amlodipine, diltiazem, can decrease the heart rate. So far, we talk about sinus rate with different, sinus arrhythmia with different rates. Now, what are the true cardiac arrhythmias? True cardiac arrhythmias can be classified based on different categorization. For example, supraventricular arrhythmia versus ventricular. Arrhythmia that comes from upper chamber of the heart versus lower chamber of the heart. By the way, with a show of hand, do you guys see me? Yes? All right. Okay, just wanted to make sure. So I have a little, I just noticed that my son also joined. So I just saw my son, Iman. Dr. Nawab Iman is here. So,
Sure.
so these are upper chamber, lower chamber, supraventricular versus ventricular. What are the other category? Regular versus irregular atrial arrhythmia. Regular, such as ventricular reentrant arrhythmia, and irregular, such as atrial fibrillation. Another category, narrow complex regular tachycardia versus wide complex regular tachycardia. I don't want to, bore you with all this categorization, but I'm going to touch upon each of this. But there is a reason that there are different categorization, because sometimes approach to arrhythmia for a diagnostic purposes is not easy. And even cardiologists find themselves trapped into a diagnostic dilemma. So if you want to focus on supraventricular arrhythmia or narrow complex regular arrhythmia from the upper chamber of the heart, there are many. Atrioventricular nodal reentrant tachycardia, or in our day-to-day practice, we call it AVNRT. That is a reentrant arrhythmia coming from AV node, around AV node, that node between upper and lower chamber of the heart. And there is the second most common, is called atrioventricular reentrant tachycardia. The difference between these two is that there is no node here. There is a nodal here, there is a node here. Atrial tachycardia, atrial flutter, sinus tachycardia, inappropriate sinus tachycardia, junctional ectopic tachycardia. As you can see, I make these gray because I already talked about sinus tach. I'm not going to talk about last two, but I'm going to cover top four. And if you pay attention, I did not put atrial fibrillation here. Why? Because atrial fibrillation is not a regular tachycardia, is irregular tachycardia. So it's not in this category. Irregular arrhythmia from atrial origin are either atrial fibrillation, which I'm going to cover in detail either today or if I get a chance in part 2. And then multifocal atrial tachycardia. Multifocal atrial tachycardia is depicted in this EKG, that unlike atrial fibrillation, there is a clear P wave responsible, but this P wave is different from this P wave, from this P wave, from this P wave, from this P wave. So there are discernible P waves, which is atrial activation, unlike atrial fibrillation, which there is no discernible P wave. But these P waves have come from different foci, therefore it's called multifocal atrial tachycardia. This arrhythmia is more commonly seen in people with chronic lung disease, COPD, or interstitial lung fibrosis, scarring of the lung. But here are the first category we talk about, narrow complex regular tachycardia. If you pay attention, this QRS is narrow, is not wide, and the interval between this and that, to this to that, is all equal. So it's the narrow complex regular tachycardia. What are the main differential diagnoses for this? As I said, those four. Let's go up. These four: AV nodal reentrant tachycardia, ADRT, atrial tachycardia, and atrial flutter. Here, I excluded atrial flutter because atrial flutter actually could be excluded, and we put only 3. AV nodal reentrant tachycardia, 60% of this arrhythmia. Atrial tachycardia composed 10% of this arrhythmia, and AV reentrant or ADRT 30% of this arrhythmia. So AV nodal reentrant tachycardia, I already explained to you the concept of reentry, how a premature beat blocks in the fast pathway, goes down the slow pathway, and restart with a reentry. Up the fast pathway, down the slow pathway. Up the fast, down the slow. And this propagates or precipitates until you disrupt this reentry or vicious cycle. As you can see here, down the slow pathway and rapidly go the fast pathway. And how do we treat it? I'll talk about it in a second. Is the most common supraventricular tachycardia in adulthood and elderly. If we, among our audience, people have regular tachycardia, there is 60 to 70% chance that you have this entity. And this entity can, in the middle of the night, take someone to emergency room because patient wakes up with palpitation and heart rate of 170 fast. It's more common in female, perhaps 2 to 3 times higher. Has a bimodal prevalence, is seen in the third decade of life, like a 30-year-old, 32-year-old female has this, or elderly at age of 60, 70, 80. Is highly symptomatic, paroxysmal, or rapid onset of palpitation, shortness of breath, chest pain, and dizziness. This is electrophysiology study that when we put catheters in the heart, when I do the invasive procedure, I'm not going to talk about this, but basically there is a simultaneous activation of atria and ventricle. But this explained to you from this atrial activity. Again, one more time, you see action potential slowly goes down the slow pathway and rapidly go up fast. So slow, fast, and rapidly going down. And cause this QRS picture that if you pay attention, this arrow that I put here, on top of the QRS, there is a little dimple here. This is a retrograde atrial activity, and that indicates that atria and ventricle are being activated simultaneously. This has a diagnostic feature for a cardiologist or electrophysiologist. How do you treat it? Even middle of the night, someone gets rapid palpitation. You can try Valsalva or vagal maneuvers. You put your hand on your stomach and you push against your hand. در واقع is like ببخشید همونطوری که you increase your abdominal pressure when someone is constipated, or that by increasing parasympathetic tone میتونه این arrhythmia رو stop بکنه. Or not, you are not supposed to do that, but a cardiologist or an emergency room doctor can massage the carotid artery, and that increase the vagal stimulation to the heart and terminate that. There are medications that in emergency room we use, such as adenosine, that can disrupt that vicious cycle, verapamil, diltiazem, or metoprolol. But if none of these work, we can shock the patient, a DC cardioversion, like you see in the movies, they put paddles and boom, shock the patient. You can shock. Or in the rare instances, we can use a very strong arrhythmia such as amiodarone. But this is too much of a Dr. Nawab, by the way, هستم بگم که at times, perhaps, when I was in دانشگاه ملی, Dr. Nawab دانشگاه ملی بودن و دیرکتور laboratory services in دانشگاه ملی بودن بیمارستان طالقانی. ما یک استادی داشتیم دکتر جعفرودی راجع به این امیودارون خواستم بگم. یه باری که بچه‌ها گفته بود ما یه بیماری استرپتوکوکی رو با ونکومایسین درمان کردیم. بعد ایشون از گیلانی هم بودن. خب پسر جان کار میکنه ولی خب عقل سالم میکنه پشه رو با پشه کش بکشی نه با بازوکا. اینم همینه. کشتن پشه با پشه کش. این امیودارون برای این اریتمیا مثل بازوکا RPG 7 میمونه. در حال. But after acute management in emergency room, what the patient needs is that see an electrophysiologist like me, and we do a invasive procedure. It's called electrophysiology study and catheter ablation of the slow pathway. If you remember, I mentioned that there is a slow and fast pathway. We go with a catheter that generates heat, and we burn or ablate slow pathway. And we get rid of it, and we treat and we cure this condition. If patient doesn't want invasive procedure, there are medications such as calcium channel blocker, verapamil, diltiazem, or beta blocker like metoprolol can be used. So this is a picture of catheters in one of my procedures. That's a halo catheter in the atrium. That is in the sinus node. Here's RV and coronary sinus. And then after we map the slow pathway, with another catheter, we go and burn that, and we get rid of that abnormal conduction. There are situations that we might use other medication, such as perhaps, might be some of the audience or all these antiarrhythmic drugs for different reasons. Flecainide and propafenone are sodium channel blockers, and sotalol, dofetilide, and miodarone are potassium channel blockers. They can rarely be used for this arrhythmia, but usually this arrhythmia is recommended to have that invasive procedure, which is curative, and get rid of the arrhythmia. When do we do invasive procedure? When AVNRT is poorly tolerated, recurrent symptom, and one severe episode in emergency room, and patient prefers the cure. When we do invasive procedure for this condition, in a study among 8,000 patients, the need for repeat procedure or another procedure was less than 1%. Long-term success rate, 99%. Complication, 0.4%. Is an excellent procedure with highest success rate and very low failure rate. So for AVNRT, the way to go is an invasive procedure and ablation by an electrophysiologist. Now, second most common supraventricular tachycardia. It's called AVRT, or orthodromic reciprocating tachycardia. Forget about this name. Let me explain to you. Perhaps you heard a condition. It's called Wolff-Parkinson-White, or WPW. You should be familiar with that because it is a condition that that individual is born with an abnormal connection between atrium and ventricle, such as this. In a normal individual, which is this picture on the left, the only conduction between atrium and ventricle is through the AV node here. But people with Wolff-Parkinson-White, beside that, they have a bundle of muscle that conducts that connects atrium and ventricle. And because of these, their electrocardiogram, pay attention here, please, here. Instead of this to be flat and narrow, it's kind of slurred and wide, and we call this delta wave. This is a normal AV transmission, and this is called pre-excitation. Why it's called pre-excitation? Because the ventricle is being excited before it's supposed to be excited. Supposed to be excited is after this delay, but because of this abnormal condition, this is a condition that it's called pre-excitation. And when this is in a combination with rapid arrhythmia, then we call it Wolff-Parkinson-White, which there were 3 scientists who together or differently at the same time describe this condition, and they have a luxury of having the syndrome. So WPW. Why this is important? This is important that it is one of the conditions that you might hear, God forbid, an 18, 19-year-old kid, completely normal, going to a basketball field or football field, in the middle of football, it falls down and is dead. That's sudden cardiac death because of this condition. I explain why. And this is the reason that I am one of those people that advocates that young kids who are going to be, even for the college and high school, at least need to have one electrocardiogram, EKG, to see if that is normal. So here is WPW, Wolff-Parkinson-White. That action potential goes both down through the normal pathway and pre-excited, and by fusion of these two, you get this weird shape of QRS, which is called delta wave. But then, when there is a premature beat comes, look at this, please pay attention here, the picture on the right. Activation goes down the AV node, goes to the ventricle, comes back up, because there is an abnormal conduction, comes to the atrium, go down. This is a classic example of re-entry. You see, it's a re-entry. It goes up, down the same pathway, and will continue until you disrupt this circuit. Another name for it is called circus movement tachycardia, going down, up and down. Normal QRS duration, there is no delta wave like here, because ventricle only activated through the AV node, but there is a retrograde P wave after QRS, which is this fat hump, negative hump, and that is because of retrograde activation or backdoor activation of atria through the bypass tract. That is AVRT, or orthodromic reciprocating tachycardia, or circus movement tachycardia. Now, more terminology. Let me make it more complex. We called orthodromic tachycardia, right? The reason of orthodromic was that going down from atrium to ventricle is going through the normal, regular pathway, which is AV node. Therefore, ortho, which is a Greek terminology for right or normal, we use. But if the propagation goes through that abnormal bypass tract and comes back from AV node, is called antidromic, opposite of normal activation. And this is the ominous and the fatal arrhythmia comes to the picture. You see, in this EKG, the patient has pre-excitation or delta wave. That's a delta wave. You see here how P and QRS are merged together. You don't see that regular interval between them. And the QRS is not narrow, it starts with slurred condition. This is pre-excitation. Then this is a condition that we just said. It's a orthodromic. Now it's going down the AV node coming back the back door. That is not a big deal. That is only cause palpitation. But let me go here, I'll come back. If that kid that is playing basketball or football goes to atrial fibrillation or atrial tachycardia, and that atrial fibrillation or atrial tachycardia, for some reason, does not go down through the AV node, it will go down through the abnormal pathway. And because that abnormal pathway does not have a property to slow down, if the heart rate in the atrium is 400, that will transmit all 400 to the ventricle. And very rapidly, atrial fibrillation going down that becomes ventricular fibrillation. And ventricular fibrillation, as you know, VFib, is that ventricular arrhythmia that is a cause of sudden death. And this is the arrhythmia. Look how ugly this is, how chaotic, disorganized. Heart rate in the ventricle is more than 300. That's a kid that is in the middle of a game, collapses and dies, unless as soon as possible you having an AED and you shock the patient. So let me go back. I just wanted to show you guys how this WPW or bypass tract, which is not rare, can be causing symptoms of palpitation, and particularly in a young, otherwise healthy athletes or non-athletes could be fatal. So what are the treatment for this condition? You need to first screen and find them, then send them to me or someone like me. These patients need electrophysiology study and catheter ablation. We will map and find that abnormal conduction and we burn it and get rid of it. If the patient, for some reason, prefer non-invasive and not an invasive procedure, then antiarrhythmic drug, per se flecainide, can be used. Beta blocker like metoprolol or calcium channel blocker or amiodarone or digoxin cannot be used in this condition and can actually kill the patient, because these are the medication that block going down through the orthodromic and push the action potential down through the abnormal connection and actually increase pre-excited atrial fibrillation and ventricular fibrillation. So this is very, very important. An internal medicine or even general cardiologist might not know that and treat the patient with amiodarone and actually increase the risk of sudden death. So this patient needs to be referred properly to a right specialist. This is the condition that we talk about. You see that bypass tract? We find this and we burn it. And here is explaining that how, if you give the patient metoprolol, amiodarone, those medication, they can block conduction through the AV node. Let me go back again. By giving those, they block this and they promote conduction through this and cause that ominous arrhythmia that we talk about. Okay, this is redundant. We talk about that. Okay, so far we talked about two most common form of supraventricular regular tachycardia, AV nodal reentry that was around the AV node, and this entity, AVRT, or atrioventricular orthodromic tachycardia, which could have a subtype which is not orthodromic, is antidromic, going down the abnormal pathway, and that can be a fatal or killer rhythm. We talk about these two. Now, the third cause of supraventricular tachycardia is atrial tachycardia. So what is atrial tachycardia? Look at this. That's a heart. That's a right atrium. That's a left atrium. Anywhere from on these two structures, there is an abnormal foci that has increased automaticity or increased trigger activity or a micro reentry, automaticity or trigger activity, and start the heart rate of 140, 150. That's the EKG look like. There is a P wave before each QRS, but this P wave is not a P wave of normal rhythm, it's abnormal. How do we treat that? When a patient comes in an emergency room in the middle of the night, like other arrhythmia, like AV and RT. You see here, in this condition, beta blocker, diltiazem, verapamil can be used because this is not what we talk about. This is not bypass-mediated tachycardia. So it's very important that you make a proper diagnosis on the EKG before you choose an agent to treat. You can use this medication if the heart rate is very fast and patient has a low blood pressure. You can shock the patient in emergency room. You can use amiodarone or ibutylide, which is our class 2B indication. We can use adenosine, but adenosine is not to treat the arrhythmia. Adenosine is a medication that can only terminate in 14 to 20% of atrial tachycardia. It blocks the ventricular conduction, so you see P, and you can make a diagnosis. Like this. Here, we had 1 P, 1 QRS. Let me go back so you guys understand. Look at this EKG. There is P, QRS, P, QRS, P, QRS. But I might not be making a diagnosis. So we give a medication with a very short half-life, adenosine, and what we see is this. It blocks, so instead of PQRS, we see QRS, P, QRS. By causing this delay, we see more P than QRS, so we make a diagnosis of atrial tachycardia or atrial flutter. What is the gold standard treatment for this? Again, an electrophysiologist, EP study, and that catheter ablation that we go inside the heart, map the heart, find where it's coming from, and we burn it. Medications can be used if the patient is extremely elderly or extremely young. They don't want invasive procedures. Beta blocker, calcium channel blocker. If that fails to control, then more aggressive treatment such as sodium channel blockers, flecainide, propafenone, or class 3 amiodarone, sotalol, dofetilide. I'm not going to, of course, if there is a question I can answer, but there are different anti-arrhythmic drugs. They are very complex. The pharmacokinetic and pharmacodynamic are very complex. I'm not going to explain all of that, but if there is a question, we can talk about it. Now, atrial flutter. What is atrial flutter? Atrial flutter is a macro reentry. Why we say macro reentry? Is a reentry that involves the whole chamber, not a localized 1 to 2 centimeter, the whole chamber. You will see when I see you the Cardo mapping. Along the tricuspid annulus in counterclockwise or clockwise manner in the right atrium. This is the right atrium. That macro reentry either goes like this, which is clockwise, or like that, which is counterclockwise. is very common in adult and elderly. It could be a primary arrhythmia, but it could be a secondary arrhythmia after you treat atrial fibrillation with some medication and atrial fibrillation transformed to atrial flutter. This is how it shows itself. Look at how on this EKG we call it sawtooth pattern. Look at this. Look at here. Sawtooth, مثل دونه های اره, like that. That's a classic finding on EKG. In an emergency room, in the ward, you see that, you say, oh, atrial flutter. This is the counterclockwise, which is negative in lead AVF, and clockwise is positive in lead AVF. Acute treatment, again, when a patient goes to an emergency room with palpitation, rate control, beta blocker, diltiazem, verapamil, or you can give class 3 antiarrhythmic, dofetilide, ibutylide for cardioversion, but not much by shock or chemical cardioversion. You give this antiarrhythmic drug and this dofetilide or ibutylide terminate the atrial flutter. Or if the patient does not respond to that, you can shock the patient. Remember, we will talk about atrial fibrillation. Atrial flutter is one of those rhythms that make the atrium in a standstill and can make or form clots and cause a stroke. Therefore, patients with atrial flutter need to be on blood thinner, anticoagulation. I will cover that in detail if audience prefer in my second talk, because I need to elaborate more on atrial fibrillation. Atrial fibrillation is the most important arrhythmia. So we talk about synchronized cardioversion, and amiodarone can be used for rate control in atrial fibrillation, in atrial flutter with acute heart failure presentation. But what is the gold standard treatment? Again, is an electrophysiology consultation, and an electrophysiologist performing catheter ablation. We find the isthmus, a narrow isthmus of the arrhythmia, and we burn it. You will like, okay, so you see that? Please pay attention to this electroanatomical map that we create. I go with the catheter in the right atrium, and I move the catheter, which looks like a broom, and we acquire information, and that information will be organized in relation to a reference point, which is a catheter in the coronary sinus. And based on being early or late, that creates this beautiful map. This is a concept of macro reentry. You see, arrhythmia reciprocate and return and re-enter and involve the whole chamber. What are these red dots? These red dots are my ablation or burning points. Each of them, we start from tricuspid annulus and we burn in a linear manner. By the time we get to the end of it, that will terminate this arrhythmia and will never come back. So this is a macro reentry going in a counterclockwise manner. This is where early meets late. So this is a macro reentry. And this is the concept of termination. You see that, pay attention to here. This is a flutter going, and while the flutter is going, I'm burning. And you see, boom, termination, and that's the first beat of normal conduction. So this is a concept of termination by burning and ablation that I said that we use it for AVNRT, AVRT, atrial tachycardia. That's how it works. That catheter, by either freezing or cooling the tissue, which is called cryoablation, or by heating the tissue with a radio frequency property, or by pulse field ablation. These are the main three energy sources we have. We destroy that excitable tissue and we terminate the arrhythmia. I put this slide here just for this smart audience to make a point between a focal arrhythmia versus a reentry arrhythmia. Look at this arrhythmia. If I ask you where this arrhythmia comes from, and a smart audience will say, I don't know, it's coming from everywhere. Everywhere is being activated. You see that? You cannot pinpoint. Therefore, for this ablation, you need to create a line to transect the whole chamber. But when I talk about increased automaticity or trigger activity, I said those arrhythmia are focal. It's coming from small 5 millimeter of a chamber. And that's an example. Look at that. That red zone in a centrifugal manner از یک نقطه center شروع میشه مثل وسط دایره and propagates laterally. That, I start from beginning, the focus of this arrhythmia is here. Therefore, برای اینکه اینو درمان بکنی, you don't need a line. Here you see I put 2 ablation point and done, we terminated. So that's a concept of reentry versus focal. Let's move forward. If the patient does not want a radio frequency ablation and you want to treat it with medication, usually we don't treat it with sodium channel blockers. We treat with class 3, which is amiodarone, dofetilide, sotalol. Amiodarone is only successful in atrial flutter in 40% of the time. But if you use ablation, the invasive procedure, recurrence or failure is only 2 to 4%. So amiodarone, recurrence 40%, ablation 2 to 4%. So common sense says that do the invasive procedure. Okay, up to here, I talk about supraventricular arrhythmia, or arrhythmia coming from upper chamber of the heart. ولی با یک exception. I did not talk about atrial fibrillation because that's a big separate entity. To be honest, atrial fibrillation alone need like a one big session. So I talk about the most common supraventricular atrial arrhythmia, which are regular, excluding atrial fibrillation because I have a different plan for atrial fibrillation. Now we're going to talk about wide complex tachycardia, including ventricular tachycardia, tachycardia that comes from lower chamber of the heart, ventricle. Those are more malignant. Those are fatal arrhythmia. They can kill, like ventricular fibrillation and ventricular tachycardia. I show you an example of them in a patient with WPW. So wide complex tachycardia composed of ventricular tachycardia and supraventricular tachycardia, meaning the origin of tachycardia is in the upper chamber of the heart, but it conducts to the ventricle with abnormal shape of QRS. We call it aberrancy, either in a right bundle branch looking or left bundle branch looking. And the third category is a pre-excited tachycardia. It's atrial fibrillation or atrial tachycardia through the bypass tract. I already covered that. That was the WPW with the bypass tract that goes from upper to the lower chamber in an abnormal wide complex configuration because of that abnormal connection. So then we talk about aberrancy. When in lead V1 of the EKG, you see a rabbit that the right is, and you look at the rabbit from back, and the right ear of rabbit is taller than left, that is a right bundle branch aberrancy. That is that when you have a conduction to the right and left bundle of the heart, and the right bundle has a block or delay, the QRS will look like that. And left bundle is when you have a little r and big negative wave. So that's a pattern recognition for a physician. When they see that in lead V1, they say this is a right bundle. When they see that, we call it left bundle. So you see that there is a wide complex tachycardia. But is this a ventricular tachycardia? No. This is a supraventricular tachycardia that conducts to ventricle with the right bundle aberrancy. That's important because this patient does not need a defibrillator. This patient needs an ablation of a supraventricular tachycardia. The origin is in supraventricle, but it mimics and presents itself differently. Has a mask that the mask said, I am ventricular, but it's not a real mask. But it's a mask, it's not a real ventricular arrhythmia. You see that how at the beginning of QRS is narrow and the latter part is wide, and there is that RSR prime, or here, rabbit, right ear, left ear, taller. This shape is exactly this shape. So it's a right bundle branch aberrancy. Therefore, is a supraventricular tachycardia with right bundle branch aberrancy. But what about this one? This is again initial part is narrow, the latter part is wide. This is not a true ventricular tachycardia. This is a supraventricular with left bundle aberrancy. Pay attention to this lead V1 here. Look at this. This is exactly what I show you. Is this. So when a physician see that, they say, oh, I know. This is not a real ventricular tachycardia. That's a supraventricular tachycardia that mimics being a ventricular tachycardia. And he says, I'm smarter than this EKG. But look at this one. Look at this QRS lead V1. It neither looks like that rabbit ears or that big negative wave. It's very bizarre, is wide and very chaotic. This is a true ventricular tachycardia. And this is could be a fatal rhythm. There are different criteria, such as Brugada criteria, to distinguish a true ventricular arrhythmia from supraventricular with abnormal conduction. I'm not going to bore you with this. This is for a cardiologist or an electrophysiologist, but there is such criteria for us. So when we talk about ventricular tachycardia, we talk about ventricular tachycardia in someone who has abnormal heart, such as heart failure, heart damage by myocardial infarction or heart attack, or valvular heart disease, and ventricular tachycardia in a structurally normal heart. So structure is normal, but physiologically there are trigger activity and can cause ventricular tachycardia. In a structurally abnormal heart, such as monomorphic ventricular tachycardia, When we say monomorphic, it means that in that tachycardia, all the QRS complexes are exactly the same shape, is monomorphic. But when the QRS shape change from positive to negative to bimodal, beat to beat, then we call it polymorphic, which has a different diagnostic indication. So example, monomorphic VT in a patient who had old myocardial infarction heart attack, ventricular tachycardia and dilated cardiomyopathy, ventricular tachycardia in different genetic disorders such as right ventricular dysplasia. So you see here, this patient's coronary angiogram shows right coronary artery is obstructed. Patient had a heart attack. And can you please pay attention here? This is a septum of the heart. You see from here all the way down to here has a normal thickness, healthy, strong. But down here, there is like a chunk, like an apple that I bite on that is gone. That's the area of old myocardial infarction. این مریض سکته قلبی کرده و این قسمت از قلبش از بین رفته. In area of a scar make the patient prone to ventricular arrhythmia. On the electrocardiogram, it shows by Q wave in lead 2, 3 AVF. You see that how it's negative? This negative indicates Q wave or old heart attack. And that patient can present with this. You see how wide and bizarre it looks? Very fast. This patient can be drop dead by that. What are the treatment? The first treatment for a patient with ventricular tachycardia with previous myocardial damage is implantable cardioverter defibrillator. One of my jobs as an electrophysiologist beside pacemaker implantation is implantation of a cardiac device can detect arrhythmia and shock the patient. Here, this is the ICD or defibrillator going down, atrial lead, ventricular lead. You see this part of the lead has a thick component. Between this and the can, patient get a shock. When that arrhythmia comes, this device detect, redetect, and deliver therapy, which is shock. If on those patients with myocardial disease and ventricular arrhythmia, there are antiarrhythmic drugs that very commonly we use, amiodarone, dofetilide, sotalol, but sodium channel blockers such as flecainide are contraindicated. It's very important. Sodium channel blockers like flecainide, propafenone can increase mortality on these patients, but amiodarone, dofetilide, sotalol, no. If VT become recurrent and patient get multiple shock, then radio frequency ablation, what I explained to you, I just show you the picture and all those cool graphic videos that they were in the atrium. We can do the same thing in the ventricle. You see here, this red means a large scar caused by old arrhythmia, creating zone of slow conduction and narrow corridor around the scar. As I explained, a premature PVC comes and initiate reentry. How do we treat that? We put ablation, we burn from here to here, and we, by the same red dots that I show you, and we terminate the ventricular arrhythmia. You see, with these arrows, I show you, I depicted the direction of reentry. And this is where we burn from here to here to close that corridor and transect that reentry. I'm going to pass these slides. These are too complex. Now, ventricular tachycardia in a structurally normal heart, not a patient who had heart failure, heart attack, or valvular heart disease. What are the examples? Right ventricular outflow tract. There is a, please pay attention here. This is right ventricle, right atrium. This is the conus or right ventricular outflow tract. And that's a pulmonary artery that takes dark blood to the lung. An arrhythmia that comes from this area, many commonly, is associated with a structurally normal heart. That's actually very common. In fact, من خودم از این area PVC دارم. With some medication is controlled. I did not have invasive procedure yet. So that's one of the entities. Fascicular VT. What is the fascicular VT? I show you those little wires in the right and the left bundle and Purkinje. Those are special electric wiring inside the ventricle that guaranteed rapid conduction through the ventricle. But each of those organizations can start a trigger activity and cause arrhythmia. And we map them and we burn them when we get rid of them. In a patient with ventricularly structured normal, defibrillator is not indicated. We don't treat with defibrillator. We either do electrophysiology study ablation or medications such as sodium channel blocker, beta blocker. Remember, I told you this flecainide or sodium channel blocker should not be used in a people with previous heart attack, heart failure, or valvular heart disease. But here, that the structure of the heart is normal, can be used and actually are high on the list to be used. So in order to choose medication for a ventricular arrhythmia, we need to exactly know in which category we are dealing with. This is the arrhythmia from right ventricular outflow tract. I will not explain how I make that diagnosis, but it's based on a pattern that I see here, and a cardiologist can make that diagnosis. This is fascicular VT coming from left bundle of the heart, mimicking that RSR prime. Look at this if you pay attention. Remember that rabbit ear, left being shorter, left, negative, right. That's a classic RSR prime. And that is positive. So this is coming from left posterior fascicle. So the treatment of choice for right ventricular outflow tract and fascicular VT is electrophysiology study and ablation. But if the patient says, no, I don't want ablation, then we can use beta blocker or class 1C drugs, sodium channel blockers, flecainide, or for fascicular VT, we use calcium channel blocker, verapamil. That is called verapamil sensitive ventricular tachycardia as well. And there are ventricular arrhythmia that happens in a patient with a normal structure heart, but abnormal electric property. And that is because of channelopathies. There are many, many channels of sodium, potassium, calcium, chloride on the cell, myocardial cell, and they can have mutation and be defective. And those have different names, different genetic properties, such as long QT syndrome, Brugada syndrome, hypertrophic cardiomyopathy, short QT syndrome. For those, defibrillator is indicated if they have risk factor for sudden death. And for example, for long QT syndrome, beta blockers is curative and prevent sudden death. For Brugada, quinidine, which is another sodium channel blocker, could be helpful. What are the entities that, again, can cause sudden cardiac death in young athletes, a college student, high school student, is hypertrophic cardiomyopathy. Look at this heart. That's a normal heart. And that's a histology of the heart. You see how these sarcomeres and these الیاف قلب چقدر منظم هستند. و in picture, you see how heart become like in weightlifters. ببینید سپتوم اینجا سایزش شده 4 برابر. Lateral wall 5 برابر. That's a hypertrophy of the myocardium. هایپرتروفی عضلات بایسپس ممکنه توی یک جوان خیلی قشنگ و سکسی باشه. ولی we don't want for the heart this. This is linked with abnormal arrangement of the fibers, which is called disarray. Simply see how arrangement of architecture of this is different from that. This is a disarray, and that kid in the middle of soccer or basketball or football can be dropped dead or right after. And the reason is this ventricular arrhythmia. If we screen that patient, the treatment of choice is a defibrillator, is a shocking device. And then patients should see an electrophysiologist and risk stratify if that athlete with hypertrophic cardiomyopathy and defibrillator can or cannot participate in professional athletic activity. That's a big medical legal dilemma and debate. All right. This is where atrial fibrillation starts.
اتفاقا من میخواستم پیام بفرستم بگم که میخواین ادامهش رو در جلسات بعدی بفرستم.
بله من سوپراونتریکولار و ونتریکولار رو تموم کردم. تو واقعا atrial fibrillation با توجه به new findings, stroke risk, Watchman and all that, obesity and AFib deserve a separate session.
بله خیلی متشکرم.
قبلا من این رو در UCLA سلامت انگار کردم. فکر کنم اینطوری بهتر باشه.
خیلی متشکرم.
خواهش میکنم. اگر سوالی هست من میتونم.
بله خانم دکتر کدیور شما میتونید استاپ شیر کنید.
من استاپ کنم. ببینم چجوری